Hello, and welcome to the Public Health Shift audio edition. I'm Nadia Tekkal. In this space, I read and reflect on each issue of my newsletter, creating a pause for public health professionals to think more deeply about how we work, what we prioritize, and what the current moment is asking of us. This episode is based on issue 27, Data Readiness, the Quiet Constraint on Digital Health. Today, I want to focus on a topic that has been coming up more frequently in conversations about digital health, health information systems, and increasingly in discussions around artificial intelligence. I recently came across a new initiative launched by the World Health Organization aimed at helping countries better understand and strengthen health information systems governance. The initiative itself was interesting, but what stayed with me afterwards was not necessarily the database that was being launched. It was the reminder that despite the enormous progress we have made in digital health over the past decade, many health systems continue to face challenges in how their data are collected, managed, governed, and ultimately used. Public health has never had access to more data than it does today. From electronic health records and disease surveillance systems to supply chain platforms and digital health tools, vast amounts of information are generated every day. Yet, our ability to translate that information into better decisions remains uneven. And that raises an interesting question. When we talk about digital transformation, are we paying enough attention to the conditions that make technology effective? Because before organizations can benefit from dashboards, predictive analytics, or any other digital innovation, they need something far less visible. They need data that are reliable, accessible, trusted, and usable. This is where the concept of data readiness becomes important. The more I reflect on digital health initiatives, the more I think that one of the challenges lies in how we define success. When a new health information system is introduced, much of the conversation tends to focus on implementation metrics. We ask how many facilities have adopted the system, how many users have been trained, how many records have been digitized, or whether a dashboard has been successfully deployed. While these are important questions which help us understand whether the intervention has been implemented as intended, they do not necessarily tell us whether better decisions are being made because of it. A health information system can be fully operational while having very little influence on resource allocation, program management, service delivery, or policy decisions. The data can be collected, reported, validated, and stored without fundamentally changing how organizations act. This distinction feels important because the purpose of a health information system is not data collection. The purpose is to support better decision making. Yet, when we evaluate digital health programs, we often focus much more attention on whether data are being generated than on whether they are influencing decisions. And I think that can lead us to mistake the presence of information for evidence that that information is actually being used. The challenge in many cases is not the absence of data. It is how to translate that data into action. When digital health challenges are discussed, the conversation often turns to data quality. Poor data quality is certainly a problem. Incomplete reports, delayed reporting, inaccurate information, and inconsistent indicators can all undermine confidence in the information available. But the more I think about it, the more I wonder whether focusing exclusively on data quality risks overlooking a broader issue. Because data readiness extends beyond the quality of the data itself. It includes governance arrangement, interoperability between systems, clarity around roles and responsibilities, analytical capacities, organizational culture, and the incentives that shape behavior. These factors determine whether information is trusted, accessible, and ultimately incorporated into decision-making processes. This helps explain something that many of us have probably encountered in practice. Why do some organizations derive considerable value from their data, while others continue to struggle despite substantial investments in digital infrastructure? Why do some dashboards become integral to decision making, while others are rarely consulted? Why do some reporting systems support learning and adaptation, while others become largely administrative exercises? The answer to these questions doesn't lie in the technology itself. It lies in the surrounding ecosystem that enables the information to be interpreted and acted upon. And perhaps this is also why data use often receives less attention than data collection. Data collection is visible. New systems can be procured, platforms can be launched, reporting rates can be tracked. Progress can be demonstrated in ways that are tangible and relatively easy to communicate. Data use, on the other hand, is much harder to observe. Understanding whether information is influencing decisions requires us to understand how decisions are actually made, who has the authority to act on information, whether data are trusted by those expected to use them, and how organizational incentives shape behavior. These are not purely technical questions. They are organizational and governance questions which are harder to answer. In parallel, in many health systems, data collection processes were originally designed to support accountability and reporting requirements. Information flows through the system to satisfy donor, program, or administrative needs. This serves an important purpose, but it can also create a structural imbalance where significant effort is devoted to producing data, while comparatively less attention is given to whether those data are being used to inform decisions at facility, program, district, or central level. As a result, the system can become very effective at reporting without becoming equally effective at learning. And I think that distinction matters because data readiness may sound like a technical concern, but its consequences are anything but technical. When data are incomplete, delayed, fragmented, or poorly utilized, decision makers operate with an imperfect understanding of what is happening within the system. And as a result, resources may be allocated inefficiently. Emerging risks may be identified too late. Programs may continue despite limited evidence of impact, and opportunities for improvement may go unnoticed. As investments in digital health continue to grow, this raises an important question for governments, funders, implementers, and health system leaders alike. Are we investing as much in the conditions that enable data-informed decision-making as we are in the technologies that depend on it? Because the question is not simply whether health systems are collecting enough data. It is whether they are creating the conditions for that data to influence decisions. And perhaps that leaves us with a few questions to reflect on in our own work. If your organization had access to perfect data tomorrow, would existing governance structures, processes, and incentives enable better decisions to be made? How much attention does your organization give to data use compared with data collection? When new digital tools are introduced, how is success typically measured? By implementation milestones or by changes in decision-making and performance? Are the data being collected primarily serving reporting requirements, or are they actively informing operational and strategic decisions? And finally, Do decision makers actually trust the data available to them? If not, what factors contribute to that lack of trust? Thank you for listening. If you would like to continue the reflection, you can read the full version of this issue by subscribing to the Public Health Shift newsletter on www.nadiatekkal.com. Until next time, take care and keep questioning how we show up in our work.